pediatric gynecologist who works with girls 0 to 24. And because Dr. Suchkin's not giving his first talk and my talk was kind of built on his talk, I want to just spend just about 3 minutes introducing the topic of endometriosis. It's considered the uterine lining that grows for reasons that are unclear outside of the uterus. It grows usually along the pelvic wall in young patients. It can grow in the ovaries as an endometrioma, although much less common amongst young patients. And the average woman has a 7-year delay in diagnosis. So most girls in a typical setting will not find out they have endometriosis until their mid-20s, and they probably could have been diagnosed in their early teens or late teens. My youngest case is a 10-year-old that I diagnosed this year after she had been out of school for 6 weeks, and she had just a small vesicular area but had horrible menstrual cramps in the first 6 months of her life. We took out that one resected lesion, and she was pain-free and back in school. So he is going to talk more about what endometriosis is, why we think surgery is very important. But I'm going to go on to build on that talk with the medical issues, because we do think it's a combined medical surgical treatment to get optimal results. So this is going to talk about the medical treatments and the timing of intervention for patients young and adolescents with endometriosis. I'm going to talk a little bit about the off-label use of lidoderm patches, norethindrone, which is known as the mini pill, the tablets, which are approved for endometriosis but not approved if you don't have a surgical diagnosis, and the IUD, which is the new player on the field. We're going to talk about medical therapies that we usually prescribe before surgery, how we make decisions about who goes to surgery, and medical therapies that we generally choose after surgery. This is a statement that I really love. Endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the goal of maximizing the use of medical treatments and avoiding repeat surgeries. If you talk to experts in the field, there are women who've had 7 surgeries by the time they get to them. They never had the right surgery with the right person quick enough. And it's really, really important that the person doing the surgery has a large volume of endometriosis in their practice, knows how to recognize early lesions, and you have one good surgery, and then you go on for medical management. 50% of girls will come back with pain a year after their surgery. That's the statistics. And even when they're done at centers for endometriosis. So we really feel medical therapy has to be a part of it, certainly for the young patient. This is the general guidelines of the American College of OB/GYN, that you start with birth control pills, non-steroidals, and then go on to laparoscopy if you fail that for management. So we're going to talk a little bit about the over-the-counter and the prescription non-steroidals, how we decide to add hormone management, and how we decide whether or not somebody goes for laparoscopy. So these are your typical over-the-counters to the left. In the middle are your prescription non-steroidals. There's actually been a lot of studies done. There's no one non-steroidal that wins out over the others. There's no one that's superior, but sometimes we'll mix and match them. For the girls on the over-the-counter, I'll say try Motrin. If you respond well, that's great. If not, try Aleve, try that. Some girls respond better to one than the other, but there's not a study that tells you one stands out. I've had kids be told that because of their stomach or because of von Willebrand's disease, which we're diagnosing more and more, they can't take non-steroidals, but you can take Celebrex, but you need to be careful because Celebrex does have a cardiac warning on it. There's a wonderful study on omega-3 fish oils in girls with dysmenorrhea. These are not girls diagnosed with endometriosis, but just girls with dysmenorrhea, and they did have lower pain scores. It's because fish oils work on the prostaglandin cascade, and his theory was developed biochemically first on the prostaglandin and the arachidonic acids, and he went on and later proved it in the schools, and a lot of my patients really feel an improvement when they add fish oils. I've had some luck with lidoderm patches. I use them sometimes during the period and sometimes for girls with chronic pain. There's no studies that I could find on that. Smoking was found to be associated with increased prolonged dysmenorrhea, so it's just one study. And there was some study with obesity. There's some new feelings about inflammation and obesity spurring on endometriosis, and in one study, being overweight at age 10 correlated with a higher chance you would have endometriosis later on. So you've used your nonsteroidals. They're still in agony. They're saying the typical story will be, my pain is only down by 10%. You know, I took the Motrin, it's just not doing much. And so then we want to go on and add hormonal management. So endometriosis is an estrogen-dependent disease, and your medical therapies for endometriosis are targeted at lowering the estrogen environment. This is going to be an issue because girls need estrogen to get their bone density. So I'm constantly playing against their bone density issues. They're in their peak of bone accrual years and their medical treatment for endometriosis, and they're sort of running arrows in the wrong direction, or opposite directions. So back to the ACOG guidelines, begin with cyclic combination therapy and nonsteroidals in any female patient with pain. So what do we use for birth control? Well, birth control, the mechanism of action is it's a synthetic progestin. It produces an anti-estrogen effect, and it inhibits endometriotic implants. We have the traditional combination pills that you all know, the different forms, and we have the newer forms coming out onto the market. The ring has a very low dose of estrogen, so we like it in endometriosis, but the patch has a very high dose of estrogen, and so it's not really a particular pick for us in endometriosis. We always want a monophasic pill. There's no reason, if you have endometriosis, that you should change the doses every week. You really want that monophasic, and monophasic pills we can use continuously. So a lot of these girls are on 6 weeks in a row or 9 weeks in a row without taking a break, and we can do that on a monophasic pill. You want a progestin-dominant pill because it handles the suppression of the endometriosis best. A norgestrel, a levonorgestrel, or a norethindrone. The newer generations, which everybody loves for acne, don't work so great for pain. And there are a lot of girls who get put on a newer generation because they'd like their pimples to go away. But you can add back the ingredient in the newer ones, which is spironolactone, and give them the older generation stronger progesterone and give them aldactone as an add back if they still want their pimple control. Emerging studies are showing, and these are small studies by Barbara Cromer, that low-dose birth control, because everybody's like, oh, you're going to put my daughter on a low dose, aren't you? No, I'm not. Low-dose birth control pills are suboptimal for bone density acquisition. So the old, put my teenager on the lowest dose is probably not panning out in science, although we don't have all the studies yet. I always aim for a 30 to 35 microgram pill if I can use it in a teenager based on the evolving concerns about bone density acquisition. But as you do a higher dose estrogen pill, you're going to run against headaches, fluid retention, nausea, weight gain, hypertension. Sometimes they feel more emotional. So that's always a juggle for me that I have to go with each individual patient. A lot of times they'll come to me and say, I tried pills, but I felt too nauseous. I had too many headaches. What do I do? Now I still have pelvic pain and I can't take the pill. Well, there's a lot of progestin-only therapies out there that are very compatible for these patients. We have to use them if you have a known risk of a blood clot, if you have complex migraines, or if you're just so nauseous or so headachy on any combination pill, we're going to go on to progestin-only therapy. So these are the ones that are available, FDA approved. You've got your mini pill, which is often used in breastfeeding. Norgestrel is Averette. It's actually kind of hard to get, so you may not find you can get it that much. And then you've got your long-actings as listed. The long-acting Implanon, I have found girls don't always like because it gives you unpredictable bleeding. And when they bleed, they have pain. So I don't find that particular therapy, while available, so helpful for somebody with chronic pelvic pain. And off-label, if they're not doing well on the mini pill because they're spotting, I will take them to a plain tablet of norethindrone, 5 milligrams, and cut it in half or quarter it, because norethindrone 0.35 is equivalent of a norethindrone tablet quartered, but I'm getting 3 or 4 times the dose. So we've added hormonal management, and they're still in pain. So if the pain persists beyond 3 to 6 months, the concern is they could have endometriosis, and the recommendation is at that point to offer them, if they're under 18, the American College of OB/GYN says you should offer them a diagnostic laparoscopy and not GnRH agonist therapy because their bones are still developing and they don't want somebody ending up on Lupron with bone issues. If you're over 18, your bones are essentially formed in terms of density. There's some very nice data that you can give somebody Lupron, and if they respond to treatment, they don't necessarily have to go on to surgery. There's a whole nother world beyond that. If you have deep lesions, you probably should have had surgery. If you have minor superficial lesions, you probably didn't need surgery, but that's a whole hour topic. The timing of laparoscopy. I want to take into consideration the family history. Endometriosis is enormously hereditary. 35% of girls, women, will pass it on to their daughters. So if there's a family history that the mother had endometriosis, that's going to influence me. Oftentimes they've had multiple ER visits, and everybody's told them, you're in pain and we don't know why. They're missing school. Early onset of their menstrual pain is a concern for endometriosis. So if early on they've been in agony, and the caveat here, and Dr. Sechkin was going to talk about this, if you have a girl who early on has terrible periods, focal to left side or right side, and or missing a kidney, the chance is very, very high that she has a Müllerian anomaly, and that's a rudimentary horn of a uterus that's not completely draining, and those need to be dealt with immediately. I had one 11-year-old this year who had been suffering, transferred out of school, horrible pain on the left side. I took one look at the ultrasound, and she had a blocked uterus that wasn't draining. The girls are born with double uteruses and one isn't draining, and she could have had her surgery 4 months earlier had the person who saw the ultrasound not thought it was just a little ovarian cyst that was going to be normal. I could tell from the history, I hadn't even seen the ultrasound, that she probably had a Müllerian anomaly. And the girls that are missing a kidney often have a blocked vagina with a double system, and that can be handled very easily. It just needs the quick, prompt diagnosis. So early menarchal dysmenorrhea, especially if it's one-sided and especially if they're missing a kidney, should really flag out right away. Focal tenderness, the little 10-year-old had point tenderness on the left side. Dysmenorrhea that gets worse and worse and worse every year, and then pain in between your periods, so pain in between those terrible periods. Those make us think this is a person we're going to find endometriosis on. So now we've scoped them and we've found endometriosis. So when we go to what are our medical goals of therapy, we've got to take into how old is she, what's the severity of her symptoms, how long has she had them, what are the side effects that she's concerned about and I'm concerned about, and what's the extent of the disease. I have a 17-year-old in my practice, stage 4 disease, and I have another 16-year-old stage 4 disease. So you can have a lot of disease at a young age. We want to limit disease progression, and there are some studies to say that therapy does limit disease progression, and we want to control their pain. These are the FDA approved treatments for endometriosis. Everything is FDA approved, it's just not necessarily for endometriosis. So Lupron is your standard. Norethindrone has come on in the last few years as a solo agent. Danazol is an older agent we don't use as much. So how does Lupron or GnRH work? It overstimulates the pituitary and leads to downregulation. It takes up to 21 days, so if 10 days after you gave her shot, she says she's still in pain, it's going to take 21 days. And there's a flare of estrogen in the first 21 days as it stimulates and then downregulates. So you can have some bleeding and you can have some pain in those first 21 days of therapy. It's available by daily injection, by nasal spray, by IM injection, and now there's a subdermal implant for 1 year that's generally used for our kids with precocious puberty, has not been studied in endometriosis. The nasal spray is wonderful if you have a patient with migraines because they get that big wompy dose of Lupron shot and they can trigger a horrible migraine. You give them the nasal spray and you let them start out and slowly kind of climb up that mountain and then convert them over because what migraines hate are the change in hormones. You can do well with your migraine patients on the nasal spray. The daily complaints are hot flashes, headaches, vaginal dryness, and I would say my patients hate the anxiety. So a lot of patients won't choose surgery because they don't want to have that feeling of anxiety. And then the long-term problem is the decreased bone mineral density. The new standard of care is that every girl on Lupron really should be on add-back therapy. The one that's really evolved, there were several starting out, is really norethindrone, 5 milligrams. It'll stabilize the bone loss, as a paper by Barbara Gordon Catherine Gordon on this showed. They had 50 girls on Lupron. Norethindrone will stabilize the bone loss and have them basically neutral. And it will decrease the hot flashes, and people usually start it right away with therapy. I want to put in a little plug, this is a little side. There's a lot of focus now on vitamin D, and I think we really need to optimize vitamin D therapy when we're giving girls things that could harm their bone density. And there's now, if you're not aware, there's a 50,000 once a week for the kid who just doesn't seem to take her daily medicine. So now norethindrone alone, Sometimes I'll use this pre-surgery, but I use it sometimes also after surgery just to get somebody stabilized who can't take regular pills. It comes in 5 to 10 milligram tablets. The higher you go, the more the side effects. We try to get somebody to the lowest effective dose to handle their pain and their bleeding. But you do have to watch moodiness, weight gain, acne, and definitely my concern about norethindrone for long-term use is the cholesterol profile and the insulin resistance. My partner had a patient in the hospital, and we had to use very high doses. She was a 10-year-old with Jehovah's Witness having horrible bleeding who could not take regular pills, and we made her a diabetic in the process. So we took her up and over that line in terms of how much norethindrone we used. So we had to. The parents would not consent to blood, and the girl had a hemoglobin of 6, and she was bleeding, and it was our only choice. But we, sometimes you do what you got to do, but we definitely learned our lesson there. Danazol actually works beautifully, but the side effects for teenagers are really annoying, and some things like potential voice deepening are not necessarily reversible. So there's the thing on Danazol. It actually works really well if you've tried everything. I've used it in the past and loved it, and my patients have liked it, but it's just not used very much now. These are medical treatments after the endometriosis is confirmed, and they are non-FDA approved. So these are some of the newer things on the market. So this is the Depo-Provera that you know, and there is a sub-Q form out that's 104. It's more expensive and sometimes harder to get the insurance to pay for it. And in addition, it turns out the bone studies were not any better. Everybody hoped that the bone studies would be better, and yay, we would have a sub-Q, Provera injection, medroxyprogesterone, that would not affect bones. But it turns out the bone data wasn't any better. So it's hard, other than less hormones, to get people to want to pay for it. Insurance hasn't been picking it up. You probably do have a little bit less weight gain, but we still have that FDA black box warning on Depo-Provera that it may cause low bone density. Aromatase inhibitors work with the idea that endometrial implants of endometriosis express an abnormal amount of aromatase. This is the tamoxifen that the women with breast cancer are on, and it leads to a rise in local biosynthesis of estrogen. So aromatase inhibitors are felt to suppress local estrogen formation, but they must be used with an OCP or a GnRH because you'll get follicular cyst development simultaneously, so it can't be used as a solo agent. But it can improve pain scores where traditional therapies have not produced optimal results. So there's a few articles where they've added aromatase and gotten good results, but we have long-term bone loss as still of an issue. So this is the new kid on the block. This is the levonorgestrel IUD. Its primary mechanism is thinning and stabilization of the endometrial tissues. It's approved for contraception and heavy menses by the FDA. It's not approved for these indications, but people are using it all the time for this list of chronic pelvic pain. People are using it for endometriosis. We're using it in developmentally disabled girls for menstrual hygiene. We're using it for uterine hyperplasia or precancer. And we're using it, there's a new case of a girl with uterine cancer, stage 2, who had her cancer reversed with the IUD and did not have to undergo a hysterectomy. So it has wonderful, wonderful uses. The first studies using endometriosis, treating it with the IUD, came out in Italy with Vercelli in 2003. He had a pilot study of 20 Paris women. And he was able to show that there was improvement in moderate to severe dysmenorrhea after surgery with the levonorgestrel IUD. He did a follow-up study where half went into IUD and half went into the surgery alone, and he showed a statistical improvement in those satisfied with their post-surgery pain reduction if they had the IUD inserted. The next study came out with Dr. Padma, and that was in 2005, and he compared a group of women receiving the IUD to those receiving Lupron and those who had endometriosis and chronic pelvic pain. Pain scores went down in both groups, but side effects were less in the group that had the IUD because you didn't have the hot flashes and the anxiety and all the issues that come with Lupron. Patients with advanced disease treated either way reported a bigger reduction in their pain. IUD users did report more bleeding than Lupron users. How does it work? Well, they did some biopsies on 11 women who underwent Lupron therapy and 11 women who underwent GnRH therapy. And cell proliferation is supposed to be one of the mechanisms of endometriosis, and it went down. Progesterone receptors went down, expression of progesterone receptors went down in the IUD, but not in the Lupron group. Expression of estrogen receptors went down in the IUD group, but not in the ectopic group of Lupron. And FAS is something that regulates, is a marker for apoptosis, which is the ability to sort of self-destruct an endometrial cell. And so if FAS is up, then apoptosis or destruction of the cells is up. And that happened in the Lupron group, but did not happen. That happened in the IUD group, but not in the endometriosis group. So what are the advantages to using IUDs in adolescents? Well, there's no user action required. There's no effect on bone density. So this to us is our biggest issue, is that we're not going to be worried about bone density because your natural estrogens are still being produced while you're on the IUD. And there's no effect on the lipid levels. And also we think no effect on like sort of pre-insulin issues that we have with norethindrone. And it's a 5-year duration. There's abnormal bleeding, especially in the first 4 months, and you really have to prep them that those first 4 months, they've got to kind of be ready for that. There's the pain of the insertion. There's the expulsion rate is slightly higher, really more for nulliparous uteruses than it is with teens per se. And teens are at higher risk for contracting an STD. They will treat, and if you get an STD while you're on the IUD, they will treat straight through. They will not pull the IUD right off the bat. And I'm going to show you a study of teenagers with the IUD. So this is a study of IUDs in young women. It's the largest study published to date. It's 233 women. They were menarche to age 21. It was retrospective. 30% had never had children. 50% were under age 18, and 95% had chosen levonorgestrel. In this study, 2/3 were in a regular family planning clinic, and 1/3 were in a doctor's office like mine that treats medical conditions of gynecology. 21% of the girls asked to have their IUDs removed. The 18 and under were more likely to ask for their IUD to be removed. I think they're the less patient crowd. 3.5% was the expulsion rate, more common obviously if you had not had children. There was a 1.3% difficulty with insertion or unable to insert in the office. They did have 7% infections. Those were typically girls who contracted an STD, only 2 cases of PID, and a certain 2% of girls, significant pain upon insertion. Every mother always worries about perforation. In this study, there were no perforations amongst all of these insertions. Investigational therapies for endometriosis. They're looking currently at progesterone receptors, angiogenesis inhibitors. We think it's sort of a kind of inflammatory angiogenesis disease, so they're looking at inhibitors. They're looking at this matrix metal protease inhibitors, estrogen receptor beta agonist, and immune modulators. I think there's a lot of thinking that it's an immune disease. And at the NIH for pain, there's a Botox injection trial undergoing. One of my patients is currently getting enrolled in. Conclusion: hormone therapy is an essential component of long-term management, pain control, and prevention of disease. Adolescent women are undergoing major bone density acquisition that's dependent in large part on endogenous estrogen. Therapies to treat endometriosis can have a significant negative impact on bone density accrual, and we have to factor in with therapy choices their age and their impact on their future bone density. The Cochrane review demonstrates that women were 5 times more likely to benefit from surgical management. Both I and Dr. Sechkin definitely are big proponents of one good surgery. The risk of recurrent lifelong disease and pain, however, is high, especially in the adolescent group. And studies that combined surgical and medical treatment of endometriosis in adolescents may retard progression of the disease in this population. So again, endometriosis should be viewed as a chronic disease that requires a combination of maximizing medical treatment and avoiding multiple surgeries. Each young woman has her own unique medical history, her own unique surgical findings, and her concerns, and they all need to be considered to optimize her medical therapy. Thank you.
We'll open up the floor for some questions, if anybody has any. Any questions for Dr. Regard?
Yes.
Every patient's symptoms are different, and when you have a young girl whose family may have some biased or stigmatic feelings about putting their child on birth control to begin with, how do you broach that
Sure.
subject? Because a lot of parents, I know it happened to me, worry that, by giving, one of the reasons that I think young girls are not sexually active is that fear of getting pregnant, as well as all the other things associated with becoming sexually active. But if there is a sense, sometimes, I know my mother experienced it, where she thought, well, I know I need to give her birth control because she's got these cramps, but I don't want that to give her a license of freedom that she may not have.
So when parents say, I don't want my child on pills, and that's very common in my office, I try to say, what is your concern? So the fear that their child will have sex is definitely top 3. Their fear that their child will get cancer is number 2. And their fear that putting them on pills will harm their fertility is number 3. So I can tell you that all mothers, it's either A, B, or C, or all of the above. Related to the question of will my daughter have sex, I can usually read it on their face, and I just say it out loud. Are you concerned that putting your daughter on birth control pills will make her have sex? I just go out and say the elephant in the room. I don't tiptoe around it. And she goes, yes. And I tell them 6 different studies have shown that if you take a group of 100 girls and put them on pills and a group of 100 girls not on pills, they initiate sex at the exact same rate. It doesn't make them have sex. They're either having sex and they're not on pills, or they're on pills and they're having sex. My putting them on pills is going to make 0 impact on whether or not they're having sex. And I say, look, if your daughter's deeply religious, my putting her on pills is not going to suddenly get rid of her entire value system and make her run out the door and want to have sex. Whatever values you gave her is what she's going to go out this door with. So I really try to just say the elephant, say it out loud, and explain what the studies are, and explain to really try to impart the values you gave your daughter are not going to walk out of this room the minute I put her on pills. Those are going to stay with her. That usually helps. The cancer one, I break it down. I say the risk of ovarian cancer goes down, the risk of uterine cancer goes down. The risk of cervical cancer does go up slightly when you've been on pills, therefore you should give her the Gardasil. And the risk of breast cancer, if she's never had a first-degree relative with breast cancer, is unknown. And if her mother had breast cancer and she's under 18 and it was premenopausal breast cancer, there are some studies suggesting we should wait till she's 18. And that's what I do for cancer. And then for fertility, I say until a new study came out this past month, which is it's going to be a long evolution. If you've been on the pill for under 10 years, at this point, there's no concern for fertility. There's a new study out about greater than 10 years users, and that's going to be controversial. Does that answer the question? Okay.
I have young children, and I would assume that some mothers and fathers would be concerned about putting them on medication so early. Do you ever get asked if there's alternative treatments?
Well, I certainly, Amy and I were talking, I certainly offer non-steroidals, I certainly offer physical therapy and, omega-3 fish oils. These are all people who've, they're missing 3 days of school, they're miserable, they're up all night with their cramps. So at that point, they are ready for, going on some kind of therapy or going directly to surgery if they're, and the reason I typically discourage surgery first is I said, look, if I look inside and your daughter has no endometriosis and she's missing 3 days of school every day, these are not people who are just taking Advil and feeling, a little crummy, then she's still going to need to be on pills to control her cramps with a negative scope. If I scope her and she has endometriosis, she's still going to need to be on pills to control the disease. So I'm not getting you out of pills by scoping her. But if she's on pills and she's feeling terrible, then you need a scope because you probably have more significant disease. I think the girls with significant disease consistently flunk pills. I don't know if there's girls out there with terrible disease who are doing great on pills, because I feel like the ones that are not doing well on pills, I'm scoping and I'm getting their disease. But that's my, we're not scoping the kids who feel great.